It says recording is begin, so it's going to move my screen again since it is keep messing me up. All right, welcome everyone. I am Yi. Today I am presenting one of the important issues that we see in the general practice, as well as for any medical practitioner working in the occupational medicine space. So this is the psychosocial hazards. It is, in fact, we are dealing with them every day in our lives, workplaces. If you work in the clinic or if you work in the hospital, regardless, they are always there. These factors are there in our social interaction with our family, not just at work. But when these factors are present at work and causing them or contributing to the injuries that you will see in your clinic, we will need to know them, because if we ignore them, our management won't be complete and that won't be comprehensive. So it is something government and other organizations are becoming more and more aware of that as well. So in fact, different state departments are starting to collect the data on the psychosocial hazards in the workplaces, and workplaces who do not try to manage their hazards in the appropriate manner will get fines. The same with managing chemical hazards. So for example, we know that asbestos is banned in Australia, so you can't start making products that has asbestos out of the blue because it is banned. The same with psychosocial hazards. They have to be controlled. As a doctor, we are seeing people with the musculoskeletal condition, and we need to be aware of when we are managing them. So that's why I want to start, and it will take about 40 minutes presentation, I hope. And then if there is any question, I'm happy to answer in the end. Let's begin with why do we need to care about psychosocial hazards? When we are seeing someone with carpal tunnel syndrome, someone who had back pain, shoulder bursitis, neck problem, knee problem, you can name any musculoskeletal conditions. They are important contributor in their pathogenesis, and there are a lot of evidence there. So I want to show the evidence summary that I gathered from one of the search engines. So these studies were done mostly as a system analysis and system review, so that these factors were identified. Now, there are MSD is a term, musculoskeletal disorder, that may include injuries that happen due to acute injury or something that happened gradually over time. And when we look at the you can see that on the left-hand side, the high job demand, strain, low work control, low justice. These psychosocial factors are they're important contributor in development of these condition, and some more than the others. If I have to use as an example, low social support and poor collaboration in the workplace are a common theme in workers who sustain back and shoulder injuries, as well as people with stress, burnout, anxiety, and sleep problem due to the work stresses, and they have higher prevalence of, and severity of any type of musculoskeletal disorders. So these are strong evidence driven. So we need to know their causative and understand in our assessment so that we can identify and we can assist the worker in their return to work process. If you want to read or understand psychosocial hazards, and if you Google this book, OHS Body of Knowledge, you can download them freely. That's Australian from the Institute of Health and Safety. That's quite easy to read. There is very little technical terms or the psychosocial terms as you speak, and it is foundation reading, you can call it. Firstly, I also want to tell the difference between psychosocial hazards and psychological factors. So when we say psychosocial hazards, we don't mean people sustaining depression, anxiety, post-traumatic stress disorder due to work. Psychosocial factors are slightly different context. So by definition, as you can see, it is how our thoughts and behaviors and our work social environment, how do they interact? And their interrelationship is called psychosocial factors. And the factors that increase the negative side or worsening of the stress and demands that will cause psychological and physical harm as the outcome. And I'll explain with diagrams in a subsequent slide for that. Now, this is very much top overview of how they interact. So if a worker, don't think too far ahead. Imagine your internship when you are a resident. What type of hazards that you encounter? Think about it. And how do you feel if you have to see many people without having a good meal break or very little support from the registrar or the consultants, and you have to call consultant at 2 o'clock, and you worry if they tell you down or scold you for calling them or waking them up. How are you dealing with difficult colleagues, nurses? How do you deal with going to radiology department to do a CT request at 2 o'clock in the morning? So these are psychosocial hazards, and when we are exposed to them, we feel stress, and that stress can be physical and psychological. Because of that, we try to cope. Everyone has different coping skill. Unfortunately, when someone is exposed to these hazards for a prolonged period or in extreme quantity, generally three things could happen. So you could sustain psychological injury such as depression, anxiety, or burnout. Very much important. Suicide to the point. Physical injuries like musculoskeletal disorder, gastrointestinal disorder. That is very easy to spot things like reflux, peptic ulcer, irritable bowel syndrome. They are really much important. Immune deficiency is more about you getting sick frequently and prone to get viral illness, that sort of thing. On top of that, on the far end, you may develop in unhealthy coping strategies like gambling, drinking, poor sleep, getting obese, eating unhealthy stuff, and that sort of thing can happen. So none of them are good if we leave them ignored. So far, we had this is long established that these psychosocial hazards are something that we found in Australian workplaces, not just here, it's all over the world, in any workplaces. I'm not going to read all of that, but we will go through each one of them to some details afterwards. Going back to the previous diagram that I mentioned, occupational stress is that our physiological and psychological response. And that's how we respond to it. And our response skill will depends on how we are trained and what type of stress is. And even for the same type of stressor, we may respond differently if it is to the different person. Stress itself is not a disease or illness, and some degree of stress are important that keep us as disciplined and hardworking and get to our deadline, get things done. Usually exam stress are good, isn't it? So, however, if the pathway leading to it and if there is very little support to overcome the problem, and that became an issue. It also depends on our individual perception. If you feel that you are the only one needing to do the work, thinking of as a uni group assignment, if you have 5 people and you're the only one who are doing everything, you're not going to feel that so good about that. So when there is beyond a person's ability to cope with these stress, you someone can sustain psychological injury. In the occupational context, you can call that as a work-related psychological injury or work-related workers' compensation psychological claim. So psychological injury is the term they use rather than mental illness. Uh, you can include anxiety, depression, post-traumatic stress, or adjustment disorders, and there has to be a clear causative pathway between the workplace stressor and the development of the symptoms. All right, so if we look at individual, some of the risk factor, I will not go through in detail all of them because that's fairly self-explanatory. If we are, if we at work, if we need to work, see too many people within a short time, or beyond the complexity of what we can see. Usually, if you need to see complex patients at work, and this is how we feel every day, and you feel dread to go to work even sometimes. And the same happened to if you get a new recruit and he has to do or she has to do complex tasks and they may sustain injuries as well as they may not have enough recovery to, uh, to help relax the muscle. So this is an important psychosocial factor. Emotional demands are usually seen in the care, psychological or the healthcare workers, and this can be causing many healthcare workers with back pain, shoulder pain, and that is contributed by emotional demands and strains. Uh, that is not really good for their recovery. And if your role is poorly defined and there is different conflict of role ambiguity, so these are another psychosocial factors. If we see them, we may not be identifying them easily as a treating doctor, but that is something that you may need to get assistance from employer or return to work coordinator to identify this one. This one is a common thing. As a GP, I see them a lot. You may hear that the worker supervisor or manager is not helping them to recover, do not provide restricted or the modified duties, or asking them to do the full capacity work, even they have injury, and they can certainly slow down the recovery. As well as if there is bullying, violence, and aggression, these cohort of patients may experience more musculoskeletal condition, or even if they have them, their recovery is slower as well. Change. Change is that something that we all have to cope every day, and most of us has certain ability to change, especially if it is something we know coming to us and we have some control over it. But if the change happen with minimum control to what we can achieve in our capacity, we feel overwhelmed, and that makes us not great. And that may even include how things are done at work, procedural change, policy change, leader change. If there is like equipment that change, and that also increase risk of accidents and injuries. Environmental conditions is well, you can think about one of the reasons that there are not many doctors wanting to work in the rural Australia because it is remote and many migrants culturally it's hard to stay there away from your cultural similar culture group, and because it is isolated, remote, and not very friendly, and it is one of the psychosocial factors. And you're not going to fix that by just giving people more money. You need to do other things. But also in the workplaces, this is dangerous workplaces. If you work with toxic gas and fumes, and that's not really a good feeling for that. That's what it meant. And job control autonomy is something we can elicit very easily. And if most people or most worker with medium or senior level managers had a lot more control, but lower level employees have lower and lower level of job control. And when it happened, that doesn't help. They feel a lot of stress and anxiety, especially when they have injury. Another thing is that they may sustain minor strains or injury and they may not feel empowered to control their work pace. In that instance, more serious injury could happen. So support from coworker and supervisor important. That's similar to the job demand and organizational injustice. If you believe that your employer is exploiting the environment, causing the native Australian animals to die, wrecking the forest, you're not going to be very happy about uh, belong to that organization. Usually, we identify ourselves with certain organization and we take pride in that. That's a normal human emotions. And if you are feeling shameful of your employer, that doesn't help with your mental health. Recognition and rewards are important. If there is low recognition and low reward, people are not going to put in effort, and that doesn't help as an organization, as well as if you are needing to work hard with very little reward for that, people are not going to be motivated to do their job in a better shape. Individual differences. This one doesn't have a lot of influence on the musculoskeletal injuries, but that is one of the psychosocial factors. Now, this is the same slide that I showed and the second one, just to reiterate that. So we go over some of the psychosocial hazards briefly, and research has shown that many workers who had these factors at work had increased prevalence of musculoskeletal injuries. So that's one of the contributing factor for injuries or condition and something we need to be aware of. And I really like this slide. It's not very clear because of different direction of the arrow. The way I want to see that is that it is similar to any chronic condition. Think about diabetes here. So if we want to look at the contributor for someone to have diabetes, and we have these factors on the left side and the outcome of type 2 diabetes on the right side, and there are multiple level of intervention where you can do primary intervention by removing or reducing the lifestyle risk factor. Secondary prevention is more about early diagnosis and treating. Tertiary prevention is where endocrinologists are involved to treat the diabetes. And as all of us would know, as GPs, we are well placed in the primary intervention. But I also don't, I feel like gaslighting everyone by saying that. But every time somebody said that our GPs are well placed to do this or that, without very little reward, as you know, one of the psychosocial hazard that I mentioned before. Unfortunately, it is true, very much true. We are well placed to minimize harm from the system to the injured workers. So I try to say that carefully, and I'll explain why. And most of us also know that although the system is trying to help the injured workers, some of what we do also prolongs the suffering, slow down their recovery for various reasons. And none of that is done deliberately, but unfortunately, they happen. So when we are looking at the working condition on the left side, now this is in the realm of the employers. We don't need to worry about that. They need to make sure their workplace is somewhat pleasant to work with, somewhat you want to go to there in the morning and you don't want to feel dreadful on the Sunday night. Now, if there is distress or something bad happen, they can also do secondary intervention to help with the stress That you can look at as both physical and psychological injuries, and that distress will be a short-term response. If that doesn't go away, and then there will be tertiary intervention. So by the time we see patients or workers become patients, usually it is tertiary, maybe early tertiary or late tertiary, depending on where you are at. So it may be a little bit too late, unfortunately. So ideally, if we can see them, if we can catch any of them in either around secondary intervention level, our outcome will be better because that's where we could intervene them as a clinician, because primary is not something we can control. So we don't need to worry about that. The whole process is influenced by the individual and situational characteristic, as mentioned below, things like biophysical, behavioral, genetic, and social. All right, what do we do? Why are we important? It feels good to feel important, but at the same time, uh, I feel like we should be rewarded, well rewarded for doing a good job. The first thing the key message I want to convey is that most of you would have heard about flag system. When you're assessing anyone with musculoskeletal condition, this is something we must know, regardless of whether work injury or non-work injury, because that may save lives. But in this context, the flag system is used to convey the potential contributing factors, potential psychological factors in the condition. So if I go to the doctor with back pain, the first thing they should be screening is if they have any red flag. Um, let me just check. Yeah. So if they have any red flag, that's the first thing we teach registrar to do, right? So starting with the ruling of the dangerous thing called equina, um, malignancy, infection or fracture, and then we refer to them. Um, Maybe I should ask AI to generate slightly different order. After that, we also should look at different color, but maybe closer. We should look at is that orange color, orange flag. Orange flag is that if they have underlying depression or PTSD, substance use, or severe anxiety disorder, that is telling us a flag that, okay, um, even a moderate or minor injury could have more severe impact on their function, causing disability. So we could be proactive in managing their person as a holistically, not just the minor injury. So don't dismiss them as a minor injury. That may have a lot more impact on their overall well-being. After that, we look at the yellow flag. If we have, if the patient or the worker we are seeing has yellow flag, so they have pain-related anxiety, catastrophizing, how is their coping skill, and do they have poor coping mechanisms? Do they think the whole night and keep coming to you for constant reassurance? That's a yellow flag. Um, if you see someone with that sort of factors, please write it down. And that's important to explain to you why that person takes 2 years to recover from a simple injury, because we need to, if you see these sort of presentation at early stage, we can intervene them. Blue flag is that uh, it's usually their relationship. We can't really influence that. We can acknowledge them, I guess, but right, if you don't necessarily have to intervene if the worker has um, poor relationship with the employer, or if they believe that work itself is not helping them. You can challenge their thought, you can ground them to reality, but uh, you may need to deal with yellow flag and orange flag first before you get to there. Black flag is that something everyone hates. You know, one of the reasons doctors don't want to see work cover patients, for example, it's complex, rigid policy, slow process, and sometimes other team members you don't feel like they're helping the patient getting better quicker. They don't feel like we are working for the same goal, although we really are. So as a doctor, we should have a system to identify if your patient has these flags or these features. If you do have them, we need to have honest conversation about that and explain how that could have impact on their recovery, and that will assist your worker and yourself as well. You will do a better job at managing these patients. All right. Other things we could do by having that flag system is that when you are seeing someone with carpal tunnel syndrome, uh, they are doctors or surgeons who will explain to you that carpal tunnel syndrome can never be work related. It's always biological or other genetic factors related, uh, because there is no really strong evidence that carpal tunnel syndrome can be triggered by work. Yes, there are things like vibration, repetitive use of uh, tools or hand. They can cause that will explain the mechanical principle of the condition. However, they are not enough in most of the time. Usually, what is the missing piece is that psychosocial factor. If your job requires you to do 8 hours without getting a good rest because production pressure, because you fear that you're going to lose your job if you do with the normal thing, or if you're a migrant worker, you want to show that you're hardworking, you don't want to lose a job, you want to compete with the local, you want to get the favor from the boss, so you work harder. Unfortunately, you might sustain injuries as twice as the locals. That's always a common scenario that we see. So as a doctor, we need to identify how much of that is physical injury, how much is psychosocial component. Unfortunately, it is not almost always easy. I will show you. Let me come back. So, I don't know whether you can see that. Now, this book is really good. It explains some of the mechanism and the risk factor for uh, if you see injuries and what is causing them and how much is evidence-based and how much is that what we think it is, but in fact is not backed up by the evidence, like carpal tunnel syndrome, for example. So what if we know that we can avoid over-medicalization? For example, most common cause of lower back pain is non-specific mechanical back pain. We don't need to send these patients to surgeons. We may send them to psychologists or pain specialists if we have a good one. Certainly, we need to send to physio. But if you start sending to surgeons or any other interventional specialists, they may offer treatment modalities, and that could usually go down, usually not very helpful. So that's important to aware of our limitation of what we know and what we can actually treat. So that's the point I meant before. We need to know what is evidence-based, and we have to stick to the stay in that lane. Because at the end of the day, if you can't help the person, it is better not to make them worse. Um, that's important. And I understand sometimes there are patient pressure. People will come to you and asking you, can I do the MRI scan of my spine? You know that it's not going to make any difference in many of the situation, but you feel like there is pressure to do. And also you start wondering, well, what if I miss some minor or rare 1 in 1 million chance case in this situation? And then you gave in and you do the scan and found the stuff. And then people start fixated on the disc bulges and other things. So that's important to uh, provide, stay where you are, know what to do, and have a protocol for managing these things. The other factor is that the cost of doing treatment investigation paid by work cover, we are all paying. So everyone who are working in Australia, we are paying for the cost of insurance premiums. So your fire premium, your house, your gas, all the insurance premium, partly we are paying for it. So even though it doesn't come out of your Medicare or taxpayers' uh, pocket, the cost of work cover compensation is we're staying paying for it. And we also need to think about, all right, if we're using all the money up, what if the government ran out of money to pay for it? It is very much unlikely, but we also need to be smart and wise with how we spend our money on. It's important that if there are psychological factors are present, we flag them early and we explain them and we include the supported services early on. That reduces the chronicity of the problems. Unfortunately, all these things are really nice to talk about on paper, but at the same time, unless you had a good system set up, your pay for these sort of things are not that great. I'm aware of that. So physiotherapy, psychological therapy for the symptoms related to the musculoskeletal conditions, and the rehab providers. Occupational medicine can be helpful to manage system-wide problems, but usually for the day-to-day patient management, you are the specialist to do that in this context. And you are the one who think of as a playmaker in the team, rather. And communication with the workplaces, the best way is that calling the supervisor during the consultation and have very brief points update. You only have to tell them 40 seconds and less than a minute. That's a lot more effective than writing stuff on the certificate of capacity. And make sure that everyone hear about what sort of duties that you don't want them to do so that the worker is feeling empowered to follow the restriction. And we can advocate for the workers. We need to be quite careful with how we advocate as well. Our job is advocate for the advancement of the system. So we're advocating for the patient, we're advocating for the fair treatment, and unfortunately, but we are not advocating for the worker for for the sake of advocating. So that's important thing. So we do not need to believe every single thing they said. We also don't need to believe every single thing the employer said. We need to be an impartial referee. Our advocacy is that to improve the system, to improve the outcome of managing workers with a work injury. This is repeating the previous bit. Because we are a lot better at avoiding unnecessary stuff. I can say that out loud. So we know that harm from intervention, and we have seen all the aspects of their history. We know the person holistically, so we can avoid unnecessary treatment, imaging. Back pain is not deficiency of endone or targin or lack of the magnetic image in our body. So we don't necessarily have to do these stuff. And we want to encourage people to keep moving. They are not going to cause harm by moving. And it is important that that you encourage people not to become patients. They are workers, they are capable. When someone regard themselves as a patient, they give away their autonomy, they give away their responsibility. We are going to help the patients or the workers to be being active partner in the recovery process. That's what we can do. In that way, to do that, we also need to know what psychosocial factors are present. So, what you can do after this session is that you can make a list of things that I mentioned today and ask them whether they have these factors at work. And that's very easy thing to do. You don't have to do complicated surveys or questionnaires or tests. This is straightforward. Do you have this? Do you have that? If you have that, you can flag that in your certificate of capacity, and that will help to manage the case. And you can convey them to the insurer, because insurer is somewhat responsible for to keep the employer do their bits to help with the recovery. So employers have a legal responsibility to assist with your job. And if they have psychosocial factor prevalent in their workplace, they need to do about it. Common theme that we hear is that particular manager at workplace bully their staff. The employee raised a concern, but the business owner or the department head do not do anything. Well, these days you can't do like that anymore because government or the WorkSafe can actually fine businesses for not doing action with psychosocial hazards. So we really need to be escalating stuff if we can. We are not going to be able to help everyone. I don't have any illusion about that. But if you find them, and there are tools for you to help. So I asked last night ChatGPT how to summarize the point that I want to convey and what we can do in this complex interaction. So as a doctor, we can identify the flags. You can see that yellow, blue, and orange flags. That's important. And we can communicate that to the worker with consent. We can communicate that to the employer and the insurer to a certain extent. And we can refer further to see people who to help with the worker. So that may be occupational therapists or the physiotherapist to assess to help with the recovery. And we can manage the condition and we can reassure them that the complexity of the presentation. So we know we do quite well with managing the musculoskeletal injury or physical injuries. That's bread and butter for us. But consideration for psychosocial hazards is important. In many work-related, so let's say someone was gardening at home and they had back pain. Their back pain recovery is different to someone who sustained similar type of injury but in the line of work. So it is important that we are aware of the factors so that our care is holistic and get good outcomes. All right, so before I finish off, I want to include the Australian and New Zealand Society of Occupational Medicine. I'm a member of the group society, and this is our main society to promote occupational medicine in Australia and New Zealand. Please check out the website and please join. They are a group of like-minded, passionate individuals like me. We are there, and it is fun, I promise. And since the last podcast, I started webinar. I started a podcast, and this is my funny face on the created on the picture, and if you want to check out, please do. And I talk mostly about the chemicals and more technical stuff to occupational medicine, but you might find them useful. Who knows? So. That's all for today. Thank you for attending and